Okay, good morning. Today we're gonna talk about the cancer pain. I remember when I was a resident in emergency department, we've seen a lot of cancer patients who suffer a lot from the pain. And the problem is many of our colleagues afraid from giving any kind of opioid for those patients. Why? Because we think those patients are addicted. Unfortunately, 90% of cancer patients has pain. But the good news is we can control up to 90% of this pain if we give the proper medication. So our objective from this today presentation, how we trained you as a physician seeing those patients to give morphine in effective dose without any complications, to save a lot of suffer, to improve a lot of quality of life for those patients who visit us in the emergency or seeing the patient in the clinic or seeing them as inpatient with intolerable pain. So during this presentation we're going to talk about the pathophysiology of pain, how the body feeling the pain, and what is the WHO guidelines for cancer pain, that the WHO World Health Organization is the guideline that used in our hospital uh, to treat the cancer pain, and how we using morphine safely, and we're going to talk about many myths about morphine. International Association Study of Pain define pain as unpleasant sensory and emotional experience associated with actual or potential damage or described in terms of such damage. So we can say that the pain is like alarming system. If you have fire in your home, the alarming system will do announcement. If you have damage in your body, the alarming system in your body is pain told us that we have damage. So damaging is the causing of pain. So to feel the pain we have 5 steps. First step, once we get the injury, there is receptors in your body called nociceptive. This will recognize that we have damage, then starting the signals through the nerve, and this is steps we called it transductions. Once the signal goes to the nerve will take this message through the spinal cord to the brain, and these steps we called it transmission. In the brain there's a processing of the pain. Where's the pain, what cause of the pain, and these steps we called it perceptions. Once the brain make an action to get your hand away from the dangerous area, this is called medulation. So during this process takes a few seconds to happen. This is the process of the pain. In cancer patient, unfortunately, sometimes you cannot control the cause of damage, but at least you have to control the pain. So how the morphine work? Actually, morphine block the way of this signal. So he work in the spinal cord and the brain to block this message and told the brain nothing happened. So just switching off the alarming system. That's how morphine works. So the morphine is not a correction the damage, but actually decreasing the perception of the pain. Okay, now let's talk about whole World Health Organization guidelines. The World Health Organization make ladder, they called it analgesic ladder, and there are 3 steps on those ladder. First step, once the patient have mild pain, we have to treat him with non-opioid, which is like paracetamol or non-steroidal anti-inflammatory aspirin or others. If the pain is moderate, you have to treat the patient with mild opioid like codeine and tramadol. If the pain is severe, we have to go to the strong opioid, which is the morphine. So the morphine used for strong pain or the pain uncontrolled previous medications. So what does strong pain mean? The pain, if we have scale from 0 to 10, and 10 is severe pain and 0 no pain, anything more than 7 out of 10 consider as severe pain. So now, let's say the patient has severe pain, 7 out of 10, and you would like to start him in morphine, but you didn't know how to start the morphine. We're afraid that the patient maybe get side effect, get toxicity, get respiratory depression, and die. But on the other hand, the patient suffer. So how we treat the patient with morphine safely and effectively? This is graph help us to understand the pharmacokinetic and pharmacodynamic of the morphine. This y-axis is serum concentration of morphine, and this x-axis is the time. And in between we have two lines. This line is called therapeutic line. Anything below this line, the pain uncontrolled. Anything above this line, the pain will be controlled. Here is the toxic line. Anything below it, there is no toxicity, no side effect. Anything above it is toxic level. So what is the toxicity? Toxicity, if we reach the dose that can make the patient unconscious and communicating, causing respiratory depression, the respiratory rate is drop, and maybe leading to death. So our target to keep the patient in between the two lines. Start the dose. How we reach to those two levels, to a level that between two lines. To reach this level, we have to start the morphine with lower dose possible. The lower dose for morphine is 5 milligram. So we have to start the patient with 5 milligram. The duration of action of morphine is just 4 hours. So we have to give the patient 5 milligram of morphine every 4 hours to cover the pain 24/7. 24 hours a day, 7 days a week. The WHO guidelines said you have to start the morphine with low dose possible, but you have to go slow. You have to increase the dose on daily basis until reach the dose that control the pain without side effect. They said we have to give the oral medication, not IV. We have to give the patient every 4 hours, not every 6 hours or 8 hours. And you have to consider that every individual have different dose. So maybe patient A will control with 5 milligram, patient B will control with 10 milligram, patient C will control with 20 milligrams. So everybody have different dose. So what the best approach? We will start the patient with 5 milligram every 4 hours, and after 24 hours we have to assess the patient again. Let's say that the patient said, okay, my pain was 10 out of 10, and after 5 milligram the pain goes to 7 out of 10. So we not reach our target. Our target to keep the patient less than 3. So we have to increase the pain medication to 7.5. And once to reach this dose, we have to assess the patient after 24 hours. And if the pain goes to 5 milligram, 5 out of 10, that means the pain is uncontrolled. So we have to increase the dose further. So you go to 10 milligram. And with 10 milligram every 4 hours, you visit the patient and the patient said, okay, with this dose, my pain is less than 2 out of 10. So now we reach the level that control the pain without side effect. What's happened if we start the 10 milligram from beginning? The problem is maybe the patient will get toxicity and patient maybe die or had very severe side effect. So to keep the patient with this level, you have